Welcome to the Cardiovascular Pulse, where we dive into medical breakthroughs, leading technology, and healthy lifestyles. Join us as we empower you on your journey to a healthier and stronger you. Today, joining us is Dr. Ryan Gullatt. He is an electrophysiologist at the Cardiovascular Institute of the South in Baton Rouge. And Zachary, welcome.
Thank you. I'm happy to be here.
So, Dr. Gullatt is an electrophysiologist, which means he handles the electrical functions of the heart, those diseases, and those treatments associated with. So, we'll just jump right into it. Go ahead and tell us a little bit about the electrical functions of the heart.
So, the heart has a complex electrical system. A lot of people know a lot about whenever people talk about heart attacks, and that's dealing with the plumbing of the heart, but it also has a complex electrical system in the heart. And so we deal with things, whether it's from slow rhythms. So a lot of people know what a pacemaker is and have an idea of what a pacemaker is, but it helps speed up the heart. But we also deal with fast heart rhythms, whether it's SVTs, which is a different type of arrhythmia from the top part of the heart, all the way to ventricular tachycardia, and then what today's about, atrial fibrillation. That's an abnormal rhythm from the top part of the heart.
Okay, so most of us have heard of atrial fibrillation or AFib. I know that that tends to be one of the more common conditions in relation to these diseases. So let's talk a bit about what is that exactly?
All right. So atrial fibrillation is basically where the top part of the heart, the electrical system, goes into chaos. Normally, the heartbeat starts in what's called the sinus node. It's at the top part of the heart. It sends out an electrical signal throughout the top part of the heart and joins in the middle, goes to the bottom. So you get lub dub, lub dub, lub dub. And so that keeps everything going into sync. Whenever you go into atrial fibrillation, basically the whole top part of the heart's trying to beat all at the same time. Whenever the top part of the heart's trying to beat at the same time, that causes it to what's called fibrillate. And atrial fibrillation, all in the name. But whenever it fibrillates, it's kind of standing still. Everything's working against each other, and the middle part's able to slow it down, but it makes it real irregular. And so you're dealing with an arrhythmia where the top part's just trying to beat all at the same time.
That chaos sounds like a lot. So if someone is feeling that in their heart, what might they feel? Is it like a flutter? Is it like a pressure?
It actually has a very wide spectrum of feelings and symptoms that a patient has with atrial fibrillation. Some people don't feel it at all. And in a way, that kind of bothers me more than anybody else, because a lot of times whenever they're not feeling it, their heart rate's going really fast. And that's whenever we see people's heart function drop. Some people, they feel kind of lightheaded, feel dizzy. They feel palpitations where their heart's beating out of sync. Sometimes they describe it as their heart skipping a beat. Sometimes they just feel bad. They don't really understand why they felt bad, but they know that, I was feeling fine until 10 a.m. And then around 10 a.m., I just started feeling terrible. And they show up and their heart's out of rhythm. They're in atrial fibrillation. So it kind of has a really wide spectrum of, some people don't feel it at all. Some people know to the minute whenever they feel it. And they can just say that I just know that I just didn't feel right.
Are people just diagnosed with this, or is it that there are cases where it can be caused or brought on by maybe what they're doing, what they're drinking?
So kind of goes across the board. One of the main risk factors for atrial fibrillation is aging. As people age, that causes changes in the top part of the heart by itself. Also, whenever people age, they tend to pick up other issues like high blood pressure, COPD, sleep apnea. All of those are risk factors for atrial fibrillation. Now, the one thing that I can sit there specifically as a trigger that comes up not infrequently is young people binge drinking. It's called holiday heart. They go out, have a Friday night where they drink a little bit too much, and then they show up in the ER feeling awful, and they're found to be in atrial fibrillation. So that can be another risk factor as well. And that can be sometimes how they present. A lot of times, though, with the advent of smartwatches and things like that, those are picking up a lot more atrial fibrillation because their smartwatch sits there and says you may be in atrial fibrillation. They're not perfect. I can tell you there's been a number of times where the smartwatch is picked up and saying they're in atrial fibrillation and it ends up being something else. But that's another way that people end up being found out to have atrial fibrillation. A lot of times they show up to the doctor for another reason. So they show up to their primary care doctor for just their routine scheduled appointment, or they show up for a surgery for another problem. They end up being found they have atrial fibrillation. So they can show up in a number of different ways.
Tell us about the tests that are used to diagnose AFib.
The biggest thing, the number one and ultimate test is an EKG. The problem with an EKG is it's only a snapshot in time. Atrial fibrillation is known particularly early on. People go in and out of it, in and out of it. And so there's times where people can show up and they say, I felt my heart skipping a beat. I felt my heart racing at this time. It was a couple weeks ago. And unfortunately, a snapshot EKG won't pick it up because they're already back in normal rhythm. So in those patients, we order a Holter monitor or event monitor. Some event monitors are longer than others, and they just basically run a continuous EKG, and we see that for on the course of a month at times, and to look for atrial fibrillation in that way.
What treatments are available if someone is experiencing this or if they can't seem to get their heart back to regular rhythm? How do you treat that?
So whenever I go talk about atrial fibrillation, patients who have seen me in the clinic can know all these things. I always run through a number of things. Number one, first and foremost with atrial fibrillation, it is the most important risk factor for stroke. People who, whenever that top part of the heart's beating in chaos, it's standing still. When blood stands still, it wants to form a clot. So whenever blood wants to form a clot, we have to do something about that because it can shoot off and cause a stroke. We can do that two ways. One is with a blood thinner. There's common ones are Eliquis, Xarelto, Coumadin. Those help thin out the blood. For patients who can't tolerate a blood thinner, people who have had GI bleeds or unfortunately head bleeds and things like that, there's a device called the Watchman, and that reduces the risk of stroke by closing up the place that typically forms a clot. The next most important thing is I want to make sure people's rates are controlled. Whenever somebody's heart rate's going 150 beats a minute, which can happen in atrial fibrillation, that's when we see their heart function drop, and we see people who had a normal heart function, 53% or higher. Sometimes they show up and their one symptom was that all of a sudden in the last week they've been feeling really short of breath and they've been swelling. We find that their heart functions dropped to 10 to 15%. And so that really happens primarily whenever somebody's been running with a heart rate in the very fast for a long period of time. It's like your heart's been running a marathon for months on end. And the last, but certainly not least for me as an electrophysiologist, is rhythm control. Patients, this is being backed up more and more with studies that have come out recently. Patients do better in normal rhythm. I believe you were made for, your heart was made with an electrical structure that was meant to function a certain way. And if we can keep you in normal rhythm and normal sinus rhythm, then people do better. We do that with three ways. One is with a cardioversion. That's where we shock you to get you back into normal rhythm. Now, eyes get real big whenever I start to bring that up. But obviously you're put to sleep and you don't remember any of it. But that's the easy way to get you back in normal rhythm. And most of the time is very successful getting out of atrial fibrillation. But it doesn't do anything to keep you in normal rhythm. So to keep in normal rhythm, we do things with either medications or ablations. Medications work really well. We had to tailor them to the patient. Certain drugs have different risk factors from people do better on certain medications based on what all medical problems they have. But we can tailor those to the patient. And they work really well particularly for an extended period of time. Now, it may be something that the patient has to be on the rest of their life if they get put on that, because if you come off of it, people go back into atrial fibrillation because what was keeping them in normal rhythm has gone away. So an ablation, that's where we do a procedure where we go through the vein in the groin and we run catheters and wires up to the heart, and then we burn the areas that typically trigger atrial fibrillation. And that's been shown to reduce the symptoms and duration and occurrences of atrial fibrillation. And the great thing about it is, from a patient standpoint, is it's a one-day thing. So most of the time we end up being able to let patients go the same day. It's an outpatient procedure. And then they don't have to be on their medications anymore after a short period of time. So and it holds up for an extended period of time. Now, these are the primary early triggers of atrial fibrillation. There are other places, and so there may be in the future at times where it's both an ablation and medications to help out to prevent that from reoccurring. But for durable isolation for atrial fibrillation, it works very well.
It seems there are new innovations every day and new treatments available to treat these types of conditions.
Absolutely. It's one of the great things, and one of the reasons I chose electrophysiology is it's a rapidly evolving field. Even from 10 to 20 years ago, for atrial fibrillation ablation is completely different than what we're doing now. Whether it's what we're targeting or what catheters we use, that makes it work better, makes it last longer, and also reduces the complications. Now, there's also in called pulse field ablation. It's a new type of ablation that's just coming to the area and just coming to the country at large, and it basically eliminates almost every single major complication that can occur from an atrial fibrillation ablation, and it reduces the amount of time that it takes to do the ablation. So that reduces the amount of anesthesia and the risk that comes from that. So it's a constantly evolving field, whether it's from how we treat atrial fibrillation from a rhythm standpoint, also from giving more and more patients the opportunity to be on blood thinners versus also on with the Watchman device and the atrial appendage occlusion, reducing the amount of strokes that we have. So there's a lot of research going into things, a lot of new devices coming out, and it's a rapidly changing field.
Wow. With all of the innovations available and new technologies offered by physicians like you and all of our physicians here at Cardiovascular Institute of the South, it's amazing what we're able to do for our patients.
Absolutely. And that's one of the things that drew me to the group whenever I was finishing up my training. I grew up in Louisiana and finished my training in Louisiana, and everybody in the state on the cardiology side knows about this group, about the innovation and the adaptation that the group has done to evolve with the field and to be at the forefront of changes within the field. And that was one of the reasons why I wanted to be part of this group and part of this place.
We certainly encourage anyone who feels that they might have this type of heart condition or just not be sure to trust their gut feeling, see a cardiologist.
Absolutely.
Better to prevent.
Absolutely. Detection is the key with atrial fibrillation. It can prevent a worldwide of issues if we get it early and start working on it early.
Thank you, Dr. Gullatt, for joining us.
Thank you.
We hope that this has empowered you on your health journey. If you have health concerns, visit cardio.com to learn more or request an appointment. Make sure to follow this podcast as well as CIS on social media for updates. Thanks for listening.